welcome. Thank you.
Thank you, Rob. For those who don't know a little bit more about me, and just to set my credentials for this talk, I'm a really weird mixture. I'm half solicitor and half acupuncturist. So for fear of revealing my great age, I practiced as a solicitor for 20 years, so I'm that old. And I've also been an acupuncturist since 2015, when I graduated from the College of Integrated Chinese Medicine. So I'm a bit of both. Also, at my time at the British Acupuncture Council, I've done 2 roles where red flags and adverse incidents crop up, and that's I've been professional conduct officer, and I've also been head of professional standards. So I know rather too much about red flags and adverse incidents. So now moving on to my talk. There are 4 parts to my talk, starting with an introduction, why it's important to know your red flags and referrals. Then we're going to have a reminder of the categorization of referrals. Thirdly, we're going to play the red flag roulette game. And finally, we're just going to conclude and bring it all together. So, introducing the talk. Patients frequently see their acupuncturists far more than they see their doctors. And I certainly know that they tell you far more than they ever tell their doctors. You see far more of their bodies, you probably palpate them more. They tell you all their innermost secrets, including things sometimes about their mental health. So with that is a great privilege. And I remember when I was practicing, it was a great privilege when patients really opened up to you and told you those things that I knew they'd never tell their doctors. But also with that comes great responsibility. And one of those big responsibilities is knowing when to refer them on to a doctor. Just catching up with my slides now. So obviously sometimes you're seeing them for maybe 30 minutes, 45 minutes to an hour, and their doctor's only seeing them for 10 minutes. And I know from speaking to mentors and supervisors and regional coordinators that sometimes practitioners are quite confused as to what they should do when a patient presents with a red flag. And I also know that with people who telephone us at the British Acupuncture Council, sometimes people notice a red flag, and it won't necessarily be something that has been caused by their treatment. And sometimes there's the issue of should you be telling that patient to seek advice, so example, going to see their GP, or even in really urgent cases, going to the hospital, or even very extremely having to get an ambulance. Also, sometimes I know that you give the correct advice 100% by the book, and then the patient just chooses to ignore it. And then they tell you that they haven't sought the medical advice, that you've quite correctly asked them to do so. And then you're in that situation of thinking, what should I do? Should I continue treating that patient? Or do I continue treating that patient but keep encouraging them to seek medical advice? Or are you ever going to get to a stage where you say, I'm sorry, until you seek that medical treatment, I can't treat you? And then another issue that sometimes arises is maybe a patient has told you something quite serious about their mental health, and you've got really big concerns that they're either going to seriously harm themselves or another person or a child. And then there's always that horrible issue as to whether it's appropriate to breach confidentiality. But the good thing to know is that we are always there at Jeddo Road, either Jane Dubois, our head of professional standards, or myself, to help you look at whether it is appropriate to breach confidentiality in those really serious situations where you are concerned that a patient may harm themselves, another person, or a child. So there is definitely help there for you. And I also know there's help available at your mentoring and supervision groups, another great source of help in these instances. So Moving on, my Bible when I was practicing as an acupuncturist was Claire Stevenson's Guide to Red Flags and Referrals. And I know that many of the colleges have this as a textbook on their courses. I was at the Acupuncture Academy yesterday for their first day of their first years, and I saw a whole pile of Claire Stevenson's Guide to Red Flags and Referrals. And I know when I was at Kickham, we were all recommended that we bought this book. And I also know when I was a practitioner, I frequently had recourse to this book. And nowadays, it sits on my desk at Jeddo Road as a resource for the whole professional standards team, for Jane, Head of Professional Standards, Ian, our Safe Practice Officer, and for myself. So that when we get a practitioner rings in saying a patient is showing certain signs and symptoms and should they be referring, we are always using Claire Stevenson's book to make sure that we can give the correct advice. And so I've used this for the basis of my talk today. So, second part of the talk, thinking about the categorization of red flags. That might be a bit hard to see from the slides, but you probably remember that if it's 1 star, it's a non-urgent referral. The patient should be advised to go and see their GP within 7 days. So that's a routine referral to a GP. 2 stars is high priority. So again, that's probably seeing their GP, but doing so within 24 hours. The really serious ones are the 3 stars, and that's an urgent referral, and that is usually a 999 ambulance to take them to hospital. Or sometimes might be appropriate to ring their doctor first to discuss whether it really is an urgent referral if you can get through to the doctor immediately. But if you can't get through to the doctor immediately, and I knew certainly in West London it was always impossible to get through to GPs immediately, in those circumstances it would be a lot safer to refer the patient straight to the hospital and probably get an ambulance to get them to do that. So those are the categorizations for referrals, which I'm sure you all remember. We can now move on to playing our red flag roulette game. So there's my roulette wheel. Not quite yet, I've got to see who's the first patient. What I'm going to do now is find my special patient 1 to 4 roulette wheel, press it, and see which of my first patients is going to come to the room. So, who's our first patient? Right, patient 2, please. Sorry, it's not showing for some reason. No. Patient 2, would you like to read your symptoms to the room?
It's weird, but I have a sciatica on both sides. I'm feeling numb at the top of my thighs, and the numbness is on both sides, and the top of my legs feel very weak. I'm having difficulty going to the toilet, and I'm right off sex.
So what I'd suggest is that you just write down on the piece of paper that you've got with you. You might want to discuss it with this person you're sitting by and see if you can get the right answer for that one. I'll just give you a couple of minutes. See lots of looks of recognition for this condition. Okay, shall we have a think about this question? Okay, so I'm sure you probably all got to that. Possible cauda equina syndrome, a very serious, potentially a very serious condition involving compression of the nerve roots descending from the bottom of the spinal cord, levels 1 to 2 downwards, usually caused by a central prolapse disc and possibly a tumour at the bottom of the spine. The important thing is, though, that the prolonged compression of the peroneal nerve supply can lead to permanent problems of urination, defecation, and sexual function. So obviously you need to refer that as a high priority, same day to a medical practitioner, but it's not an urgent 999 one. That one always seems to come up. I do know of one practitioner where this has actually happened to, so it's an important red flag for us all to be aware of. Yes, is that a but? Yeah. I definitely agree with that. For the purpose of an exercise, it sometimes has to be fairly clear-cut. But I do agree, as practitioners exercising your clinical judgment, before you make any decision, you will be asking all those relevant questions. So I'm sorry if I haven't included every single possibility when I've done this. Otherwise, we'd have been here well past the time for my talk. So yeah, for the purposes of getting us done in 45 minutes. But I agree, professional judgment is really important. Thank you, Susan. This one. So we'll have another go. Patient 4, please. I was really proud of my roulette wheel, but we can't see it. Very disappointed. Here we go. Patient 4, over to you.
I fainted on the bus on the way here. I was only out for a second or two. I think it was because I didn't have any breakfast and I haven't had any lunch yet. I'm feeling much better now that I've had a cereal bar and some water.
So you just want to think about that one for a couple of minutes. There we go. Hopefully you all agreed, a possible faint, not usually necessary to refer people for fainting to a doctor or the hospital, although obviously if there are other more serious symptoms, you might need to do so. Other symptoms could be faint lasting for a long time, symptoms worsening, blood has been lost, dizziness and confusion, rapid pulse, blood pressure being really low, cold and clammy extremities, or possibly or known diabetic. Everyone agree with that or have anything further to add? Obviously, these are all the kind of questions you'd want to be asking them before you make that decision. So, yeah. So, let's have another go. Patient 3.
What does it mean that my blood pressure is 200 over 115?
And the other bit.
Also, I have type 2 diabetes.
Oh, thank you very much. I think that's a more tricky one. I always found it very difficult to remember all the different blood pressures. Okay, did you all agree severe hypertension, systolic pressure over 180 but less than 220, diastolic pressure over than or equal 110 but less than 120, the major risk factor being with this patient that he has diabetes, but there are other potential risk factors like past history of heart disease, chronic leg ischemia, and also kidney disease. So this one, priority routine referral to a medical practitioner within 7 days. Are people all happy with that one? Yeah, I think the important thing with blood pressure is also remembering that different types of patients, the blood pressure ratings are different. So say, for example, pregnant patients or patients with diabetes or patients with established kidney disease, they all mean that generally they're expected to keep their blood pressure within a lower range than the general public. So yes, that's a good one to remember. Personally, I used to have all the blood pressures on a little card, so I could always quickly refer to them without having to go all the way through the book. So, yes. Yeah, yeah. Yeah. That's true. I agree, definitely. One, asking the questions, and two, taking the blood pressure yourself. But I guess then there's always the issue about how accurate your blood pressure machine is compared to the doctor's. But I think, if in doubt, isn't it, that you would take it, and if on your rating it's saying that, you'd send them to the GP and let them check it. I guess another issue is quite good that seeing you as a practitioner, they're usually a lot more relaxed with you. So I think there's much less likelihood of sort of like the white coat syndrome. I know certainly when I go to the doctors, my blood pressure goes up, but I see my acupuncturist and it usually goes down. So I think it helps you get a really good picture of their blood pressure. And again, you might be seeing them more than they're seeing their doctor. So can I have my final patient? It must be patient number 1.
Since you put the needles in, I'm not feeling very well. I am breathless and my chest hurts when I breathe.
Oh, I hear all the... So, did everyone agree a possible pneumothorax? I say possible, not a definite, but even if it is a possible, there is still that duty to refer them urgently. And this is a 999 one. I wouldn't even think this would be a good one to ring the doctor on first. Not all pneumothoraxes are caused by needling. There can be spontaneous pneumothoraxes. Sometimes if a patient has a broken rib, they can get pneumothoraxes. I've also heard of occasions for spontaneous pneumothorax for patients who are very old with serious lung conditions. These are all possibilities. So even though it's not your fault that the patient's got a pneumothorax, that responsibility as a professional practitioner is still to refer the patient appropriately. The reason why I want to highlight this one, I have had 2 circumstances where practitioners have telephoned me where there has been a potential pneumothorax, and on both occasions I really had to persuade and get quite assertive with the practitioner and say, you must refer them urgently. We won't talk about it anymore now. You get an ambulance there, you refer them urgently now, and then we'll talk about how it was caused, then we'll talk about reporting to the insurance company and doing an adverse incident report. But initially, you must just get that patient urgently referred. So I've been quite shocked at the 2 occasions where I've really had to be quite assertive to get practitioners to refer those patients. And you'll also see there, rather shockingly, we do have approximately 1 possible pneumothorax each year. And I got that figure from the insurance company. I meet probably about once a quarter with the insurance company, with Rob, and both with Lockton's and RSA. And they provide me with a list of incidents that have been reported to them and that they're dealing with cases. Not all the possible pneumothoraxes are actually caused by our practitioners, so there's often that question of causation, but they do crop up about once a year, so it is one that we do have to be very careful on. And also, I think you'll find that Ian may refer to it when he talks about his adverse incident reporting in his talk coming up after mine. So I've only got 4 patients, but I've got some questions. Yes, Felicity?
Did you, in those 2 cases,
I must admit, I don't know, because usually once it's been referred to the insurance company and they talk about causation, I don't always get to hear about the end of the case. I think one's a very recent one, so we're waiting to hear. The other one was a pneumothorax, but the question of causation, whether it was a spontaneous pneumothorax because the patient was very old and very thin, or whether it had been caused by the needling by a very experienced practitioner. So I don't know the result of that one, but I'll look it up. Yes, Felicity. That sounds a brilliant idea. I would talk to... yeah, it's quite shocking. I think it's a really good idea. I will talk with both Jane Dubois, Head of Professional Standards, who's going to be speaking third, and Ian Stones, our very good Safe Practice Officer, who's going to be talking about adverse incidents and what to do. The three of us will get together and collate those figures, and we can send them out, one to members and also to the colleges, so you can use that. And I know that BAB, I think, also want them to think about incorporating them into their training. Yeah, no, that'd be good. Any other questions on this one? Is that a question or not? No? So that's urgent category call 999. So those are my 4 patients. I'll now come to my conclusion. So that's the wrong one. Right, so where are we? So obviously I've got 3 things I'd really like to encourage practitioners to do. Firstly, think about refreshing their knowledge of the red flags and referrals, because I know it's very easy for them to go stale, and it's great to have the book, but to have them in your head, I think would be a really good way of achieving some of your CPD. So I'd recommend that as a way of achieving some CPD for the year. Joining a supervision and mentoring group, because obviously that's a good, safe environment to discuss when to refer patients and difficult issues when you have a patient where you've given them clear lifestyle advice and recommended that they go to see their doctor or go to the hospital, and if they've point blank refused to do so, you know, what situation are you in and how do you deal with that? Because obviously the patient might not like it that you're advising them to go to their doctor or their hospital if they don't trust Western medical professionals. And I think that often comes up in the mental health arena. And it's often the mental health arena is the one when you have to make those very difficult decisions as to whether it is appropriate to breach confidentiality and maybe to contact the doctor yourself. Those are very, very exceptional cases, and we do have a number during the course of the year where we have practitioners telephone and want to talk about is it appropriate to breach confidentiality. I would always look at the GMC guidelines. There's some fantastic GMC guidelines about when it's appropriate to breach confidentiality. And I'll always go through those and ask questions of the practitioner. And between us, we'll come to a decision whether it is appropriate to be referring maybe to their doctor without the patient's consent. But generally, you should be trying to get the patient themselves to go to the doctor or their nurse or mental health nurse. Check your first aid certificate is up to date. That goes without saying. Sometimes you might be required to do first aid on the job. Very important. And obviously stay on for Ian Stone's talk about adverse incidents, because I know he's going to be talking about how to deal with patients if there is an adverse incident to maintain rapport, and also about completing an adverse incident report for our purposes. And one of the reasons for getting these reports in, it's not because we want to punish the member who's had an adverse incident, but it's to gather statistics. So if we are going to be reporting statistics to the membership and the colleges, we need to make sure we can get our statistics as accurate as possible and know where the trends are, know where the issues are arising. Having said that, generally it is known that acupuncture is a very safe practice, I know when I speak to the insurance company, and they deal with dentists and osteopaths and physiotherapists, and on the whole they think that our members are very safe and we have a very low level of incidents, and for that reason they're not putting our insurance up this year. So I think that's, ever since I've been doing the job the last 3 years, our insurance premiums for the medical malpractice and professional indemnity have remained the same. So the risk of our practitioners is not increasing, but it's still something we need to be monitoring what's happening. And we'll be posting you a CPD certificate after the 3 talks from Jane, Ian and I, so I don't know whether anyone's been circulating a register so we get your email addresses that we can do that. But finally, I just want to emphasise that we really are there to support you. If you do have any issues, I would say that your starting point would be Jane Dubois, who is the head of professional standards, or Ian Stones, who's the Safe Practice Officer. And they will help you do 2 things. They'll help you work out whether it is one that you need to be reporting more urgently, and help you deal with some of the issues relating to the patient. And I've got a horrible feeling I have run very short, so if anyone does have any questions, I'll be more than happy to